Everybody see it all right? Very good.
Yep.
Okay, so the ACM levels of care, it's kind of unique. I wasn't really aware of the ACM levels of care until about 2 years ago or so. For those who don't know, historically, they've been around now. This is actually their 30th anniversary of being published, so we should probably have a little birthday party for ACM. Excuse me. But they really go a long way to directing where we place people and you know, what kind of services we can offer them. So that's me, that's my family. Daughter was a little younger when this was taken. She's a little older now, thankfully, but only 10 months. All right, so jumping right into it. I don't have any disclosures. I have no pharmaceutical ties. I also am the president of the West Virginia Society of Addiction Medicine, WVCAM, so I guess it's kind of near and dear to my heart to some degree. I really do want to thank Dr. Zhang. I don't think he's on here, and Dr. Farmer. They're actually the ones that taught me a lot about ACM, because prior to them kind of speaking to me about it, I really didn't know a whole lot about the ACM levels of care until a couple of years ago. So the objectives of this, we're going to kind of my universal addiction treatment algorithm, and I think that's important just to kind of segues into the ACM levels of care. We'll look at them kind of in general, overview of them. We'll look at the 6 dimensions that we use to evaluate where to place people. We'll talk about the various levels and some examples briefly, and try to have some fun in the meantime. So really, the way that I approach any kind of substance use, so for those who don't know, I work at the DDU, so I run the DDU these days. So we have some pretty sick people that get admitted. So really the way I'm thinking about it, anyone that comes in the hospital for any substance of abuse is, one, you know, do they need to be in the DDU? Say if I'm seeing someone in the ED, where are they most appropriate? So are they appropriate to go to a really high level of care, or do they just need outpatient? So inpatient versus outpatient versus residential is kind of its own thing. So kind of triaging someone. If someone's in the hospital, or really any level, is you want to stabilize them, of course. So you want to prevent any withdrawal symptoms. So, you know, we talk a lot about opioids, but thinking alcohol or other things too. So we prevent any withdrawal symptoms, and we also want to manage any kind of medical complications they might have. So often, you know, folks dealing with Hep C, that's more of a chronic condition, but say somebody has endocarditis and they need medical care ASAP, right? Very important. And then we're trying to work on any relapse prevention methods. So if they're in the hospital, we're starting on MAT. You know, the way I think of MAT is it's not just opioids, it's really for any substance of abuse we use MAT, but particularly for MOUD, or medications for opioid use disorders. So we know they're very effective. And then lastly, if someone's in care, no matter what level they're in, the goal ultimately is to get them in some kind of outpatient. And so you want to try to arrange the appropriate follow-up before they leave. So figure out where they need to go, stabilize them, get them on good medicines, and then get them in the right level, like kind of down the chain. So what are the ACM levels of care? So they were found initially in the text of the ASAM criteria, treatment criteria for addictive, substance-related, and co-occurring conditions, 3rd edition. This was 1991. They're widely used for patient placement in the appropriate level of care. So they were kind of disjointed efforts in the past to, you know, figure out where folks need to go. And this was a way to kind of make a universal criteria that everybody can use in the US, and try to have some common language to use when we're placing people. Unfortunately, it is also, for those who deal with insurances, there's kind of the pros of ASAM levels of care, but then there's sort of a flip side to it as well, which is that the insurance companies are well aware of the ASAM levels too, and so they'll use them to try to kind of reject people being in higher levels of care. So I don't know if we have any insurance folks on. I'll try to be nice. But really the goal with ASAMs is to match the people to the right level of care. The right level is actually the ideal level, which Dr. Zhang has talked about previously when he's spoken about this. I don't really go into that a whole lot, the evidence behind it, but suffice to say, the evidence points to that if you can match somebody to where they really need to be, that's ideal. But it is better to overmatch, and the worst thing, not better than ideal, but it is better to overmatch than it is to undermatch. So say somebody should go to, we'll just throw out a number, 3.7, and that would be the ideal situation. If you put them in a 4.0, that's not so bad. If you put them down and like, oh, you're fine, you go to outpatient, that's bad. Okay. So there are 6 dimensions of care, which I'll teach you kind of the way that I was taught it, because I think it's easier to remember when you're trying to do these evaluations. And we'll go from there. The scale is it's one of those weird scales in medicine that we use. So it starts at 0.5 and it goes up to a 4. 4 is the highest number. The higher your number, the higher the intensity of care is. So for example, 1 is an outpatient, 2 is intensive outpatient or partial hospitalization, whereas a 3 is a residential / lower level inpatient services. And then lastly, the highest levels of medically managed intensive inpatient services, such as the DDU. This is just kind of, again, it's think of it as more of a continuum, but 0.5 is technically what we'd say early intervention care. Kind of interesting. 1 to 2 is really this outpatient. When you get up to 2, and we'll go into these more in detail, but 2 to 3 is more of an intensive outpatient, and then 3 and above is really where you're talking residential / inpatient, kind of a medically supervised detox versus full-blown medically managed intensive inpatient services. Okay. So the dimensions when we're talking about, where should we put people, what ACM level of care, we're really looking at 6 different dimensions of this multidimensional assessment. So the 6 that we look at are acute intoxication and or withdrawal potential. So how sick is somebody from a substance use standpoint? So do they, have they had withdrawals in the past? Are they in withdrawals now? Do we need to treat this? Secondly, biomedical conditions, complications. This can kind of branch off of the substance itself or be its own separate thing. So somebody might be in DTs and that'd be biomedical, or they might have raging diabetes that's not controlled, or some other medical thing that might push them to a higher level of care. 3 is emotional, behavioral, cognitive conditions and complications. So kind of my wheelhouse, psychiatric issues. So figuring out where they are, how psychiatrically stable they are. So those are the kind of the big 3 at first. And then you're looking at more dimension 4, readiness to change. So how ready is someone to get help with their substance use issues? Dimension 5, relapse, continued use or continued problem potential. So figuring out how much of a problem or how much of a risk is relapse. Lastly, recovery or living environment. So this is kind of an interesting one. The longer you've been doing this, the more you understand that really this is where the game is kind of won or lost often is, where are people going to after this? Are they going to be stabilized and on the right medicine, but are they going to end up living under a bridge afterwards, or they have somewhere to go to that's enriching and that'll help their recovery, not hurt it? So the way I was taught to remember this by the good Dr. Zhang is the ABCs and 3 Rs. Hopefully some of you heard of this, but A is for acute. So how acutely sick are they, withdrawing, right? B is for biological. So biologically, physically, how sick are they? C is for cognitive or psychiatric. So how are they suicidal? Are they homicidal? 4, the 3 Rs, so ready. So how ready are they to get better? The other R, relapse potential. And lastly, recovery environment. So ABCs and 3 Rs, that's the 6 dimensions, easy peasy, right? So looking into these people, again, typically we have a screening. We'll diagnose them with alcohol use disorder, opioid use disorder. How severe is it? Figuring out how ready are they? Do they actually want to come in? Do they actually want to get help? What's the likelihood they're going to relapse if they don't get help right away? We look at these dimensions, right, when we're deciding where are we going to place them. Is it simply an outpatient issue? Is it something that needs higher intensive outpatient, or is it somebody all the way at the top that really needs medically managed intensive inpatient? And again, this is a spectrum, so people might start lower and they move up, or they're doing well and they start moving down. But anybody have any questions so far? I think it's pretty straightforward. Hopefully it is. All right. When we're really looking at the placement criteria, if someone is outpatient, you'd expect you don't want them to have a lot of risk of intoxication withdrawal or, horribly medically complicated. That's probably not somebody that you want just directly an outpatient, or someone who's suicidal, they're not going there. this is a good place to kind of look, okay, the recovery environment's pretty supportive, right? So they can do fine outpatient at home. You look at more like an intensive outpatient, less structure, less support. And again, we're less focused on the intoxication, the medical complications, psych problems. We're looking a little bit more in terms of readiness for change, the relapse potential, recovery environment. When you start getting up to highest level, we're not even talking about these readiness for change, relapse potential, or recovery. We're really focused on how sick are they? How sick are they? Are they at severe risk? Do they need medical care right now? Are they suicidal? Do they need somebody watching them? And then kind of in between is more the sweet spot for a lot of people where you're talking, rehabs or residential programming. So there's some risk possibly for withdrawal. Sometimes they have medical problems. There's still some ongoing psychiatric issues. They might have some resistance, or they need continued motivation to stay sober. They're still at a high risk for relapse, right? Because they're not doing very well. Or lastly, they don't have somewhere safe for them to go afterwards. So just looking at kind of each level, we'll touch upon it briefly, but really level 0.5 is early intervention. So this is for, we're trying to catch people before they start having problems. So people that are at risk for developing problems, kind of trying to treat them where they are before it becomes an issue. So really just about anybody would be appropriate for 0.5. Anybody with a family history, those are the people you really want to, early intervention for everybody, basically, baseline. Outpatient services. So this is typically consists of less than 9 hours a week. So there's a lot of wiggle room in there. So what you really see is most outpatient stuff that we do. So kind of the COAT model, this is really a level, a level 1 is in outpatient services. Nothing more, nothing really less. When you're talking about an intensive outpatient, which is considered level 2.1, this is where you're seeing people, multiple times a week or multiple hours each time. Maybe like a higher level of a COAT program where you're having people seen very often. That could kind of fit in there a little bit. But really, like at Chestnut Ridge, because I use us as an example, but at IOP, like an addiction intensive outpatient program or the ACT program, assertive community treatment, we're actually going and seeing people. That kind of fits into an inpatient, intensive outpatient service. We're looking at more at partial hospitalization, so 2.5. This is really a day hospital type situation where someone's going in every single day, for 3 or 4 or 5 hours each day, getting treatment. So they're not necessarily in the hospital the whole time, but they might as well be getting the same care that they would in the hospital. When you look at, so ACM 3.1, this is something that we often lack in the state. So most residential treatments that we have are 3.5, which are just a little below kind of an inpatient detox. But at 3.1, really, this is a place that you can get 24-hour living support and structure. You have people there. They do some therapy, but it's not as intense. So they're not doing therapy 7 hours a day there. What we really have right now, and I'm not aware of too many of these places, but we have this healing house now, which is kind of a new thing in Clarksburg. In the past, some of you probably familiar with John D. Good and Bob Mays, those were technically 3.1. So you'll see people stay at a 3.1 for 90 days or 180 days or, a 1-year program. That's kind of where a 3.1 fits in. So it's a residential, it's run by somebody, but they do have access to care. They're not really detoxing per se. There's still a risk for relapse. There might be some psychiatric stuff, but it's relatively stable. So nobody who's unstable. And keep moving up the line. So really, there is this, what is called a 3.3, which is a clinically managed population-specific high-intensity residential services. You'll notice in life, there's splitters, there's lumpers. Some people kind of split the ACM levels even more. We're like, we'll get a 3.2 in there somehow. But these are like very, again, it's kind of a population-specific site. The best thing I could mention would be pregnant postpartum women, that program. So a very specialized thing focusing on one type of clientele. So that's what a 3.3 is. And again, this is kind of can be a longer program, 90 plus days. Up to 3.5, which is really what most people think of when they think of residential treatment. So basically 24-hour care with trained counselors, lots of treatment, complex issues, co-occurring things going on. CHH residential is a good option, a good thing to kind of note, but just about any rehab you can think of is a 3.5. Now the issue becomes is, when talking from like an insurance standpoint, is that really insurance is the whole 28-day thing was kind of built around insurance. So how much would insurance be willing to pay for someone to go to treatment? 28 days. So that's why they made it 28 days. The problem is that some people are at 3.5. They probably need to stay longer, but a lot of times insurances won't let you go beyond 28 days. Sometimes they won't even let you get to 14 days. And then they want you to kick them down to 3.3 or a 3.1 or maybe straight to outpatient. And so that's the constant kind of battle you have, is figuring out where is somebody now versus a week from now. Where should they be? Again, ideal to match, better to overmatch than to undermatch. So kind of going under is a problem. Next, we have the ASAM 3.7. This is really kind of what you'd consider a detox, just kind of a straight detox place. So subacute biomedical and emotional behavioral cognitive problems. So they're not in imminent danger of someone of hurting themselves, but they could be clinically still not very stable, and they need medical monitoring, but not necessarily as intensive as a hospital. So really, like Hope and Healing, we have a detox unit, and there are other detoxes out there. I'm sure some of you work with them. But this is pretty much as high as you can get without being straight in the hospital, which is what ASAM level 4 is, the DDU basically. So medically managed intensive inpatient services, 24-hour nursing care, daily physician seen, because they have severe unstable problems with the ASAM dimensions 1, 2, and 3. We're not so focused on the readiness to change or the relapse potential. So being on the DDU, I couldn't argue that someone needs to stay at an ASAM level 4 just because they don't have a place to live, basically. But if they are at a 3.7, say, you could make the argument if their living situation is so malignant that they need to stay a little bit longer. So hopefully that makes sense. There are these withdrawal management levels. I'm not going to go into this too much because, again, there's kind of lumping and splitting, but basically kind of mimic the other things that you're seeing. It's a little different, kind of ambulatory withdrawal management. You don't see this used a whole lot. So maybe for like someone who's, not on a huge dose of opioids and they're kind of getting ambulatory detox. But I wouldn't focus too much on it, just to kind of let you know it exists. This looks overwhelming, so I won't go into it too much. But again, we can just kind of pick one out. So we've talked about 3.5 because that's kind of the most common if someone's going to residential. But we'll say dimension 1. So this would be the psych dimension, or excuse me, the acute withdrawal dimension. So minimal to severe withdrawal risk, managed withdrawal. People really shouldn't be in withdrawal to be in that level, right? None are stable, so you don't want somebody to be biologically, medically very sick to be at a rehab, right? 24-hour setting for stabilization, so they might have some psych issues, but they're not trying to hurt themselves, severe or unstable as you would a 4.0. But then again, you'll see, again, going kind of down the line, they need skills to prevent continued use or relapse potential. They have some issues with treatment. They're somewhat ready, but they still have problems with it. And lastly, you could justify keeping someone kind of at one of these levels, 3.1, 3.3, 3.5, just because the environment is pretty bad. Again, you can kind of ignore these. This is just an example of what you'd see, but it doesn't go into necessarily justifying somebody being at a 3.7 or 4. All right, so just briefly into the levels of review. So try to keep this kind of short and sweet and leave some time for discussion, but it's really a continuum of care. You see everything from early intervention, which is 0.5, to the level 4, which is an intensive inpatient. So for example, COAT would be a 1, IOP or an ACT program is a 2.1, the day hospital is a 2.5, the Healing House would be a 3.1, PPW is a 3.3, residentials are 3.5s, dedicated detox is a 3.7, and lastly, the kind of highest level is inpatient psych hospitalization that manages addiction. Sometimes you will hear these kind of further levels that are divided, so kind of a residential withdrawal management. Don't get too worked up about that. There are the 6 dimensions to assess. So we have the ABCs and the 3 Rs: acute, biological, cognitive, or psychiatric, and then readiness to change, relapse potential, and recovery environment. Again, the ideal is you want to match the patient to the level, but it is better to overmatch than to undermatch your patients. But at the end of the day, we live in a world with insurance companies, and you know, it's good. I would say that it's great to be knowledgeable of ACM levels to facilitate people getting the right place, but also just know that as long as you do this, you are going to come across it when you're dealing with insurance companies, and they are always going to push you to have somebody at a lower level, sometimes whether it is appropriate or not. All right, so what questions do we have? Hopefully that was pretty on the nose. We'll see. All right.
Thank you so much. That was excellent and very informative as per usual. So yeah, what type of questions, if anybody wants to use a raise hand method or just unmute themselves?
I'll answer your question right away. So it is Buffalo Plaid Mondays on the DDU. So we are changing the floral in the summer times, but I almost forgot that Mitra wore her buffalo plaid and Elizabeth wore some kind of plaid.
Shut up. It is totally still plaid. It looks better on me. Gotta do color wise, you know? So everyone, you feel free whatever color plaid works.
Yeah. So I'll wear floral for the next presentation.
Yes.
Quiet crowd today, my goodness. We all still have some Easter candy that we're I'm gonna get out of the share here.
I guess this is David Baltiero, so more of a comment, and that was really helpful because I've always had trouble with the ASAM levels and all that. It's, you know, yeah. As a family doc, we just kind of tend to do stuff, and sometimes those categories are tough, but it seems like the part that we struggle in terms of treatment in people, it's really the environment. So, I mean, this whole, you know, people going into treatment, 28 days, they come out. And, you know, I'm not sure a lot of the, you know, not saying locally or stuff, but naturally the industry puts people in treatment, but really doesn't look at their environment afterward. 20 days you're out or 20 days you're back in. And I don't know if you want to comment on that. You know, I mean, I think in some ways the outpatient, if people aren't so sick, you know, we're dealing with their treatment environment, their living environment, because that's where they are, and we have to do it. But I'm not sure, you know, I've had many people just get discharged into the world with no plan.
Half the time without medicines even, right?
Right, absolutely.
Yeah, which is disturbing. Yeah, I mean, the ideal situation for me is if somebody's really bad off would be detox, rehab, ideally a sober living type place if possible. And that's kind of like its own thing too. That's not really an ACM because remember, a lot of this is insurance driven, right? Whereas a sober living is more kind of outside of insurance that they're paying for it on their own. I would love it if insurance is paid for it. But I would say that's ideal. Now, if somebody can't do that for whatever reason, then knocking them down to like a 3.1 if it's available would be great. You know, it is tricky, but yeah, the idea that just sending someone to a 28-day program is going to cure everything, you know, is not the way it works. And, you know, for those who know much about the way some rehabs are run, like the everybody aware of the Florida Shuffle probably by now, I think I mentioned it. But yeah, I mean, there's some rehabs that their business model is based on people relapsing and needing them back as soon as possible. So I think connecting people to as much care as they're willing to do afterwards, if they have a rock solid home situation, sober people, then that can work. But a lot of people that we see probably need to be in some kind of sober living or, you know, 3-1 or something like that, ideally.
Yeah. Or even just living. Sometimes, you know, having the right home or even just stay home, you know, that's, home, you know, a lot of times.
Homelessness, plus substance use plus stimulus checks equals bad. We'll put it that way right now.
Thanks.
You're welcome.
So, thank you, Dr. Husted. I remember Dr. Zhang presenting on this before, and I think that I'm so new to this that I'm still just absorbing little by little. And so my question, so it was good to hear this again today. And my question is, I still don't quite understand how the levels are used in communication. Is it mostly to communicate with their insurance, or is it that we communicate with each other saying, I think this person needs a 3.1 or a 3.3, or is it, anyway, I think that's my question.
The insurance companies know what every facility is.
Yeah.
You're kind of labeled. Yeah, you're labeled. So the insurance company, what they'll do is they'll say, okay, Joe Schmo is in the DDU, which is a 4.0.
Okay.
Do they meet criteria? If not, I want to force them to go to a detox or get them home. You know, when it comes to communicating, I mean, the idea, I think it's good for us to know, because then we can decide, okay, how well is this person doing? Again, are they going to leave and be homeless if we send them out a residential or a, you know, intensive inpatient? Can we send them? Is there a 3.1 in the full knowledge that if I knock them down a level, it buys them more time with their insurance, right? So I think that's where it's important. The insurance companies know what it is. And again, they're trying to kind of weaponize the criteria. I was at AAAP conference about 2 years ago, a year and a half ago. We had a whole discussion about this. Funnily enough, they didn't bring up much about how the insurance companies do use it against us. But to me, that's like the thing that concerns me the most is the idea that they could use kind of your own criteria to undermine your efforts for treatment. I saw it from a chat. Dr. Morrison was saying ASAM criteria on the boards, but it wasn't a real world problem. ACM criteria is that they don't have an easy way to transition from IOP to residential. So we lose a lot of patients there. I guess so you're meaning going up the chain from lower level to higher level, would you say?
Yeah, it's a logistical issue. So what we have at Cabin Creek, we have in residential. So, but we have lots and lots of patients who, by ASAM criteria, should be in residential.
Yeah.
And so, how is that possible? Well, we don't have it.
Yeah, if we don't have it, then it's not possible. I mean, there needs to be more beds. I think there's enough 3.5s now, honestly. I think what we really need is like 3.1s anymore. We need long-term places people can live at, plus or minus sober living places, plus I would say, plus sober living places that they can transition to after which. But the 3.1 is, I mean, if anybody wants to start at 3.1, I'll send you patients there, I promise, after so you don't have to worry about it. But the other thing too is if someone has relapsed, keep in mind that most residentials won't take somebody fresh off of a relapse. So a lot of times they're going to get kicked up to a 4.0 or a 3.7 to at least make sure they are stable. So again, better to kind of overreach than underreach. So kick them up to a 3.7, detox for a couple days, then get them into a 3.5, unless it purely is someone struggling but they haven't relapsed and they just need to be in a rehab, which is a thing. You don't have to necessarily have to have relapsed. You just have to be struggling, so you become homeless, you have a lot of cravings. That's justification based on ASAM levels to get somebody into like a 3.1 or even a 3.5. So that helps. I expect everyone to wear buffalo plaid next Monday, by the way. So go ahead. You have something else, Ron?
Sorry about that, Dr. Hirschler. I hit asked on mute, my bad. But I think that Tony should be the one that decides what we're going to wear. I mean, it is her didactic. So if she wants to go,
Okay.
she'll let us know. I'll let you know too.
You have to think about that.
Yeah, you can take your time.
Jennifer, I was just going to say one thing about outpatient work and levels of care.
You know, when a patient is struggling, you want to think about all those dimensions in assessing the patient, and then try to determine what is the appropriate place for this person's pathology and their psychosocial situation, and you know, what's the right level of care for them. And you can document that. If it's not available in your community, at least you've attempted to give them the appropriate medical treatment they deserve or require. And you know, so it's kind of demonstrates with some evidence what the appropriate treatment is for people based on what's happening in their situation, their clinical situation.
Thanks.
Everybody know their ABCs and 3 Rs now? It's a good way to remember it.
Excellent. Thank you so much. Are there any other questions or further comments for today's session?
Elizabeth, I have a medication question if
Oh
that's
yeah,
permitted.
I apologize.
No, that's
Oh my
okay.
gosh.
That's fine.
Yes, we have time. Go ahead, Jennifer.
So I have a question about the use of Seroquel. I've had a couple of people come into the program recently who have been prescribed Seroquel, and they say it's for sleep or for restless legs that they experience. And I don't usually prescribe Seroquel. For years and years, PAs weren't even licensed to prescribe antipsychotics, and we have a hard time getting people in with psychiatry here, and so I've covered these guys until they could get in with the psychiatrist. The question came up recently: is does it have an abuse potential, Seroquel?
Absolutely.
Okay, can you tell me more about that?
Sure. So anything that's sedating, it's often abused in prisons. So you want to hear the fun names? So the two that I know are quelling. Okay, so quelling is one name, and then sleeping with Sarah is the other one. But people will abuse Seroquel because of the sedative properties. If you look at the chemical structure of Seroquel, it's kind of like 2 benzos stuck together. It's not like everybody abuses Seroquel that's on it, but it certainly has abuse potential. It's not a scheduled drug, but out of all the antipsychotics, it's the most abusable. You know, the best indications for Seroquel are bipolar disorder and schizophrenia. Medicaid won't pay for it if it's just for sleep, usually. So if you tried writing for like a low dose, often it'll just get bounced back at you because they realize you're just writing it for sleep. Sometimes acutely in like treatment, you'll put somebody on Seroquel if nothing else will work. But it's generally a good idea to avoid it unless you know somebody has a really good reason to be on it, put it that way.
And does it have a street value? Could they be, because these guys were also, one of them was lobbying to have an increase in his dose, which I did not do. He ended up seeing the psychiatrist, and he did do, and I just wondered about can you divert it? Can you sell it?
If it's abusable, it has a street value. So,
okay.
Yeah. Now, especially in prisons. So in prisons, I mean, anything's abusable. People will snort Boost bars. People will snort Wellbutrin. Tylenol is abusable. You name it. It's more of a prison thing, but you will see it as an outpatient, some people diverting or misusing it.
Mm-hmm.
Another thought about Seroquel for sleep is that it has a kind of a problematic side effect profile. It can cause diabetes and hyperlipidemia, and you know, there's a lot of serious side effects that occur with antipsychotics that make it really a poor choice for something like insomnia.
Yeah, so sometimes if you tell someone like, I don't know if you really want to be on that strong of medicine because that's used for schizophrenia and bipolar disorder, and it'll probably eventually give you diabetes, plus you gain a lot of weight usually on it. Sometimes that alone will tell people like, hey, maybe I should try something a little different. Sometimes not.
My understanding too, it's a contraindication for restless leg syndrome. It actually makes it worse.
Right. That's right.
Interesting. Yeah, these two
But
guys.
a lot of people think they have restless legs when it's not actually that. It's probably more like a dyskinesia at night. So that anyone tells you that, just tell them to get a sleep study to make sure they're doing it the right way. Because we use D2 agonists, not antagonists for restless legs.
These two guys were started on it in prison and were really, anyway, really lobbying heavy for it. And when I put, you know, I just referred them to the psychiatrist, but when I put the kibosh on the conversation was they were trying to convince other people in group that it was a better thing for them to take than Remeron. And I said, well, I'm the prescriber and I'm not starting on you on Seroquel.
So some prisons have actually banned Seroquel, not just abuse potential, but just the fact is like it was being over-prescribed because it basically just turns people into zombies if you're on enough. So they wouldn't be violent, but they'd be kind of like high all the time. Hence the quelling away the years, as they say. So the other antipsychotic you want to be a little careful with, not really addiction potential, but I don't know how many use Abilify, but Abilify, if you've ever sat in on a Gamblers Anonymous, they hate Abilify because it can make you more impulsive. So it's a partial dopamine agonist. So like Abilify, some people will start using more. So that's usually one we stay away from. So Seroquel because of the addiction potential and Abilify because it might kind of drive you to relapse or impulsive behaviors. So Harrison County is known as Quiet the Pain. I like that. Seroquel. Quiet the pain, quiet the pain.
Thank you so much. And then per Google, as a Morrison put, its street value is $3 to $8 for 25 to 100 milligrams, also known as baby heroin, or when combined with cocaine, a cue ball. So yeah, that definitely has a street value to it. And
if you want to have a little bit more fun than good old Dr. Google, there's always StreetRX.com. It actually has some resources at the bottom too. It's really kind of a funky one. It's like the Wall Street ticker of all this street talk and prices. Apparently people have jobs to just troll the internet and find these prices. It's pretty amazing. If you're ever doing presentations, you could always pull up like the city that you're in and pull it up on your slide and whatnot. All those medications, otherwise known as substances that we were just talking about, this is like my favorite interprofessional conversation. What the heck do you need the drug guy for? Pharmacist, by the way. Guys and gals are amazing. Purely my opinion, dime a dozen these days. But another way of looking at something like quit the pain. I just learned that. Thank you. Who shared that? Dr. Morrison, thank you. It is, you know, like we've talked about, I think in other records like gabapentin, you know, like should it be controlled? Well, it is and whatnot in certain areas and all that. Completely different mechanism of action, but kind of the same lump. There is clinical utility for these things when dosed appropriately. It's all about the dosage, of course, and the indications. So completely different mechanisms, but really the same kind of idea there. Like, yeah, there's a lot of bad sides. There's some spots where you could use it. But, you know, Dr. Boyd, I like yours there. Well, you know, I'm the prescriber, so I got that going for me. That's, I'm gonna quote you.
Definitely the easy way out.
I was going to mention one other thing. I forgot to put it in the slides, but one thing we've been developing here at WVU is a universal referral form. So the idea is if anybody, now we're talking about residentials and different treatments, if you've ever tried to refer somebody to these various things, you might have to fill out 25 forms to send to 25 different places. So one thing we've worked on is actually a universal form that every place is going to start taking. So I think we'll probably send that out afterwards too. You can look at it. It's not like copyrighted, you know, I don't get paid for it or anything. But it's something that we've been doing at the DDU. We've been sending to all the rehabs and it's really made life easy. So one form you fill out and you just copy it, send it to wherever you need to go. So hopefully, because I know sometimes it can be very daunting at all the different places and filling out all the forms. I mean, you could spend hours and hours just trying to send out referrals. So one referral to many places, that's the idea. So
thank you for that. That'll be super convenient for those, and I can include that too if you'd like to push that over to me.
Jeremy, do you think that we should have an ambulatory detox level of care?
I've done it a few times, and yes, but I don't want to be the one that runs it. So there you go.
Would it be with the IOP or the day hospital, or how would they do that?
I think it would have to be something different. So for those who, I don't know if anybody else has one, but the idea that you could detox some people just coming in, you know, multiple times a week. I know there's some people we've interviewed that are interested in that, but I think that would be a really good thing to have because not everybody is willing to go in the hospital. You know, somebody still has to feed your cat, right? So, and of course you can smoke at home. You know, might not get to smoke at the DDU.
Or if they have children or something like that.
Well, you know, pets too. So, all right.
Hey, my pet turned 1 today, so she's my child right now. Any other comments or questions today? All right, so you'll get a little bit of time back. 10 minutes, it's good. My only announcement right now is for our next session, and that'll be occurring on April 26th, and Tony DiGiacchio is going to be presenting on best practices. All right, thank you everyone for joining in today, and have an excellent rest of your day.
See you later.
Thanks,
You're welcome.
everyone.